of Emcure Pharmaceuticals Limited welcome you all in another session of no thrombosis. So since last 2 years, we are conducting these sessions every monthly, and a lot of discussion we are doing for the cath lab procedures and the cases which has been challenging cases which has been done in cath lab. So we feel this no thrombosis is dedicated to all interventional cardiologists across the country who are interested into the vascular interventions and imaging and live recorded case discussions. So it gives me a pride, privilege, and honor to welcome our course director, Dr. M.S. Hiremat sir. Sir has been a director at cath lab at Ruby Hall Clinic, Pune. Sir has been a past president of CSI in 2017 and convener for National Interventional Council of India of CSI from 2004 to 2006. Sir had proctored many interventional cardiologists and given live courses across the globe. Though coronary interventionist at heart, he is equally adept at peripheral arteries interventions like leg, carotid, and aorta. And sir has been a part of many groundbreaking trials. Welcome, sir. Today we have with us Dr. A. Srinivas Kumar sir, a senior consultant cardiologist and director of cardiology and clinical research at Apollo Hospital, Hyderabad. Sir is a chairman of FACT Professional Services and a founder editor of National Medical Journal of Postgraduate Medical Clinics of Usmania. Sir has been a founding course director of Advanced Cardiovascular Solutions in India, ACVS India, TCT India, and South Asia Conference. Sir had an interest of TAVR and TAVI, ASD and VSD, and sir has been a president for Cardiology of Society of India of AP chapter, and sir has been a principal and co-investigator in more than 10 clinical trials. Thank you very much, sir, joining us. It's indeed a nice and privilege to have you once again as a course moderator in this session, sir. I also welcome our course moderator, Dr. Girish Navsundi, sir. Sir is a director at Cath Lab and senior interventional cardiologist at Apollo Hospital, Bangalore. Sir had performed more than 4,000 angiograms through a femoral, radial, and ulnar approach, and almost 1,600 angioplasties, both coronary and peripheral. Sir has been a first cardiologist to implant absorb stent in a private healthcare sector in a state of Karnataka, and first cardiologist to implant MRI compatible ASCD system in the state of Karnataka. He's also a first cardiologist to implant tapering coronary stent in the state of Karnataka. So sir is joining in some time. Now I would like to welcome our speaker for the day. Our first speaker is Dr. R. Pradeep Kumar. So he is currently working as a head of the department at Cardiac Sciences at Jayaprakash Hospital, Roorkela. He is an alumni of CMC Vellore and a faculty at CMC Vellore in a department of cardiology as well. He will be presenting endovascular stenting in coarctation of aorta of a young adult. Our next faculty for the day is Dr. Krishna. He is a senior interventional cardiologist at Sentinel Hospital, Vijayawada. He will be presenting a prosthetic valve thrombosis. So this would be our agenda. So we'll be having two back-to-back cases and a discussion in between. So with this short note, I will stop here and I will hand over this session to our faculty for tonight. Shall we start, sir, our case? Hello, am I audible? Yes.
Yeah, I'm okay. So, sir is okay. Shriman sir, you checked with sir?
I think sir is joined, but sir's video is not reflecting. So maybe we can start.
Okay, no problem for me.
So we can start.
So Dr. Pradeep Kumar is also joined, sir, and Dr. Krishna is also there. So we can start with any one of them.
So Dr. Pradeep Kumar, can you start your case, sir? I think this iPhone is Dr. Pradeep Kumar, sir.
Yeah, yes, sir. Yes, sir. So I think we can start with Dr. Krishna Chanda, sir. So then we'll move to them.
Yeah, Dr. Krishna, sir, can you start your case?
Yeah, sure. Yeah, good evening all seniors and my masters. So thank you for giving me this opportunity. Are you able to hear me?
Yes, sir. Yes, sir.
Yeah. Today I want to discuss about prostate valve thrombosis and use of thrombolytics in day-to-day life. So case one is 30-year male, non-diabetic, non-hypertensive, is a known case of CRHD. He underwent mitral valve replacement, St. Jude in 2019. He presented with the class 3 and class 4 dyspnea since 2 days. He stopped the medication for 1 week to undergo some dental procedure. So on examination, BP is 90/60 and pulse is 86 and SpO2 of 88% and normal temperature. And on auscultation, there were no heart sounds audible and there were bilateral inspiratory crepitations. 2D echocardiogram showed thrombus attached to the anterior disc on the LV side with decreased or non-mobile clot of 6 into 6 mm. And transesophageal echo was not done because patient was in cardiogenic shock and needs immediate intervention. And the mean gradient was 22 mm Hg. So he was thrombolized with altiplus 10 mg bolus followed by 90 mg over 90 minutes. So patient was monitored for success or failure of hemodynamic improvement by serial transthoracic echocardiography every 6 hours and for any complications. So 2D echocardiogram did not show any improvement in the gradients and thrombus was still like 5 into 5 mm with class 3 symptoms. So he was again thrombolized with tenecteplase with a slow infusion of 40 mg or 24 hours. After successful thrombolysis, heparin was continued, infusion was continued, and acetylmol was added later on, and aspirin of 75 mg daily, and the target INR was maintained of 4, and counsel patient to take adequate measures and discharged in the stable condition. This is my first case. Shall I go to my second case also?
If it is similar, you can continue.
This is a second case, 60-year female, non-diabetic and hypertensive. She presented with class 3 symptoms since 2 days. She underwent mitral valve replacement of ATS valve in 2005 of 23 mm. Her vitals were stable, SpO2 of 94%, and there were muffled cardiac sounds, and there were bilateral crepitations, and the mean gradient across the mitral valve was 23 mm Hg, and the PT-INR was 3.65. She underwent a fluoroscopy, which revealed restricted movement of one of the leaflets of prostate mitral valve. We can see that one of the leaflet is not moving, which is a bileaflet valve. So she was advised a mitral valve replacement later. These are my two cases, sir.
Yeah, good evening, Hiramat sir. Good to see you, sir. You want to start?
So good.
Yeah, we were wanting you to say some welcome words. We are waiting after a long time again for the delegates.
No, you can do the same job. No
Okay,
problem.
thank you again. Thank you, Emcure, Emcure, for again restarting this. I think sir is very passionate about this and a lot of interest over the doctors across. And for a change, we are starting with a different type of cases. Previously, most of the times we discussed about coronary interventions with some thrombus, but now thrombus elsewhere, Dr. Krishna brought. So this thrombus on the prosthetic valve here, thrombus is not wanted here. No, obviously it is not wanted anywhere, but more so on these prosthetic valves. So prosthetic valve thrombosis, two cases which you have presented, Dr. Krishna. First one was what make, you said. Second one was what make. Second one was TTK valve, you said. First one was what valve? Both are mechanical valves, obviously.
Sir, both are bileaflet valves, sir. First one also
St. Jude's.
St. Jude, sir. The second one
So-
is EPS bileaflet valves.
So first one we missed, the INR was in therapeutic range. Second one you said it is higher, 3.6 actually.
Yes, sir.
First one?
First one is sub-therapeutic range, sir. We thrombolyzed the case.
Okay.
He has initially stopped his medication for 1 week because of some dental procedure.
Yes, yes. So surgery duration before this happened for both patients?
It was like 5 to 10 years before, sir.
Oh, after so long, huh?
Yes, sir.
Okay. So drug non-compliance is a cause in the first patient, and second patient we don't know exactly, you're saying.
Yes, sir.
So sometimes generally we see it is a little more in shorter time. 10 years is little longer, but it can happen anytime. By and large, as you cases are showing. But straight away before we recommend MVR, like in second case, did you think of trying the same therapy in the second case also? Did you do TE or anything?
We have done TE, sir, but there was thrombus and also pannus that was round circumferential pannus was also, it was making the valve not to move, sir. One of the leaflet was not moving. So we decided to replace the valve, sir.
True, but before directly submitting to repeat surgery, probably many times we did try giving lytic therapy. Various forms of thrombolysis we tried. Previously, streptokinase, urokinase used to be given. Then we had some experience of giving tenecteplase. You gave retiplase. And but initially, only thing which you need to be careful is also caution them regarding the embolic events which could happen once the valve is getting lysed. But even a little of lysis and the gradient significantly come down and patient's pulmonary edema improves. We have seen such cases. And depending upon the etiology, obviously on the transesophageal echo, if there is still the residual thrombus, residual pannus, then probably gradients won't come down and patient may not improve dramatically, but at least some improvement will be there even in such cases. What we have noticed in acute stage, because second case also you said huge gradients and patient was in pulmonary edema, then giving such could help even in spite of pannus being there.
But
Acute, whatever.
INR was higher in range, sir, 3.6. So
Yeah, this is again sometimes many patients have varying NRs. So checking also is a problem sometimes, but it's always a worry. So bleeding is also a worry. But people have tried various means. People, one of our colleague, Dr. Hariram, took them to cath lab and just pushed the valves with a catheter, and it opened up. So patient was almost about to die. Then he took it, nothing to do. Then valve opened up and patient survived. Human body is also great sometimes. And no embolism, nothing happened. And in Madras Medical Mission, Dr. Ajit Molasari group also put some filters and tried to balloon dilate these thrombotic valves in spite of pannus being there. And they have sent some data about 7-8 patients later with some initial first patient, no carotid filter, nothing was used. In emergency, it was done. Nothing happened, valve opened. Whereas they now put some filters later and then tried doing in some patients. There is some just paper published. So this is a problem. The best thing is to avoid it by proper anticoagulation. But in spite of it, sometimes it tends to happen. In elderly people, that's how we tend to move more towards the bioprosthetic valves where this problem is less common. So we should also consider, sometimes I feel seeing these deadly problems, it is not a bad situation where patients can be given bioprosthetic valve and redos can be done later, maybe after 10-15 years, because once the valve degenerates, that is the problem. So, but this valve thrombosis, once it happens, it's a deadly problem. People have tried Novax in that, nothing worked. Only acetylene works again. So that is a problem we noticed in such valve thrombosis patients. All of us might have had some experiences. Aortic valve, because of high pressure differences, is less thrombogenic, but mitral valve, we do see a lot of some patients coming with thrombotic events. Sometimes TIA episodes also will be there in some patients, and patients could have atrial fibrillation, need not have atrial fibrillation also. So diagnostic modality, as you said, is first by transthoracic suspicion, then doing a TEE, then fluoroscopy is generally confirmative, valve leaflets do not move. And sometimes we also thinking in pregnant females, Also, you could, instead of stopping this azithromycin and restarting all that during pregnancy, also sometimes could lead to trouble. So some in European consensus, people were telling even in early when they want to become pregnant, they could have even a bioprosthetic valve implanted, and later once it degenerates, you can again decide. These are some of the things, but data are evolving. Our surgeons are quite good, but in spite of that, if the patient do not follow the anticoagulation, it will land in trouble like this. And people have tried to see different particular type of valves, whether each of it is which is better. Some people said tilting disc better, some people bileaflet is better, but by and large, bileaflet gradients are less. That's what our surgical colleagues say. So, but most important is saving the patient in the acute stage. Whatever you do, little of it opening saves the patient in acute stages. I think the first patient was saved like that by you. The second patient still, if it is okay, tolerating hemodynamics, it is okay to send. But otherwise, some sort of in spite of INRs being high, also we gave low doses and still patients did improve. Your comments, Hiramat sir?
Yeah, I think both were managed very well. I'm actually getting sort of moved away from the mechanical valve because,
Yes.
I mean, if it is a city patient like say Pune or nearby city, then I don't mind putting a valve which needs anticoagulation, mechanical valve. But if patient is coming from some village, you can make out by one look at them that this is not going to be a very reliable patient. I would probably think of a bioprosthetic valve. Also, as Srinivas mentioned, young females want to have pregnancy and baby. Again, bioprosthetic valve, let it last as long as it lasts, and then you can change the valve with a mechanical valve. But I think anticoagulation, the INR results are also not the best across the country. I mean, so many times you get results which are very different from standard lab. So I'm very suspicious about the INR value. And I would probably feel that you give TPA, TNK TPA, and then follow it with low molecular weight heparin, and that would be about 3 to 5 days of an overlap between these two. So what is the optimum time to do an echo? I mean, you could do an echo just at the beginning to make a diagnosis, but at the end of about 8-10 days of aggressive therapy, we talked about TNK TPA, low molecular weight heparin, and while he's on low molecular weight heparin, do echo. And that would decide whether you need to change the valve or you can continue with the same valve. Are there any surgeons in the discussion?
I think Hiramat's a renewed interest for the interventional cardiologists again. The bioprosthetic valve is, suppose the valve degenerates, nowadays we are doing TMVRs. So same valve, instead of changing it, you can do percutaneous procedure. The ring is there, then you can put a valve. Same aortic valve in a reverse position, we do it in the mitral valve position. We did have some experience in it, but that generally is done in elderly patients who are not fit for surgery as of now. But if data comes well and patients do not want to redo surgery, then that could be another option in future. So that is another incentive or whatever you call interest for to use a bioprosthetic. When you see such thrombotic patients, we feel very frustrated. INRs coming low, high. There are INR kits also, home monitoring kits are also available, but still a lot of challenges. I think Girish joined, sir, our other moderator. Girish, are you there?
Yeah, hello. How are you, Dr. Srinivas? And
Yeah.
it's nice conversation, but my experience is very limited because I'm a pure, corporate doctor where we don't see much of this. My surgeon does probably about 5 to 10 valves, so it's pretty limited. But as I think both of you have covered, Hiramat sir and yourself, quite a bit. I think listeners have had earful.
I think.
It's not enough earful, it should be brainful.
Sorry for the grammar, sir.
Thank you.
Quite mindful. Yeah, thank you, sir.
I think Onkar, we didn't target any surgeons, no? Sir was asking any CT surgeon opinion.
No.
CT surgeons also, sir, initially they wouldn't like to operate on a redo patient with thrombotic valve. They will say, please stabilize if possible and all that. So it will be helpful to stabilize patients. That's good, I think. If there are no further comments or questions, any chat questions or anything, or we'll go to the next case.
I just wanted to ask one thing, Dr. Srinivas. Do you find the surgeons, are as enthusiastic as cardiologists to intervene in acute situations? I find it off late. Probably, there's a lot of holding back. I won't call it reluctance. They would probably like a much more stable situation to operate rather than, criticality of the patient, because oftentimes their morbidity and mortality is more than ours. So are we correctly judging them, or what they are doing is right?
No, that's what I was mentioning. No, they won't like it. They will say most of the time stabilize the patient little and all that. But they have their own problems, I think.
Thank you.
I would feel, yes, I mean, taking up a patient who is stuck, when valve is stuck, and so many things going wrong, and doing a repeat valve replacement is so best to address the way you did, Dr. Krishna.
Yeah, thank you, sir.
But I'm not exaggerating, sir. Hariram, he published also. He took a patient in emergency because in that patient, the worry was he was in shock, and INR also, he was telling it is high. So he didn't know what to do. He took to cath lab and they just poked the valve with a catheter. In the retrograde way or what, immediately I did that, not transeptal, but it did work. And some flow, it came, then it started pumping, then cardiac output improved gradually, and patient again, for later on, later stage, I think it was sent for surgery, but acutely it survived. In the same time, if you want to send for surgery, the patient would have been, by the time everything is arranged, it is a problem. Similarly, that attempt of balloon dilatation, that is more transeptal, and passing the balloon and dilatation, that is what Triple M group did, again in emergency. Initially, it survived, then later on, they were trying to see whether you can put filters and avoid embolic strokes. That first patient which they did in emergency had a stroke later. So that was it. Then now people are trying to do even because aggressive TMVR is coming up, people are trying to do even in mechanical valves with filters, whether you could rupture that valve, and there's a case report published in European Heart Journal. They did rupture the mechanical valve, and human body looks great to me. Small pieces got embolized, but nothing happened. Patient, I was told in that case report. So, in future, we could get more long-lasting bioprosthetic valves because of material preparation and the way these grafts, valve leaflets are prepared, and is better. And now we have 15 years survival bioprosthetic valves. So we could have a better valve. So that could be a better solution, though they are expensive, but that they avoid all these problems.
No, avoiding anticoagulation is of great help, I think.
Yes.
Even if you have a very intelligent patient, or for that matter, a doctor who is a patient with a valve change, getting a correct INR over a length of time, over a length of years, I think it's really, really tough. Something or the other happens. Some need for, say, anything like dental extraction to a trauma and a surgery. All these are on the sort of, I mean, stopping is a difficult game. So I think we must have bioprosthetic valves which are going to last longer.
Yes.
Yes, I think the Edwards are coming with this Resilia, which is a dry valve. They claim it would last 25 years. So if that comes in and it proves its durability, I think it'll be a great gift. And they're loading that onto their new Sapien valve. So they claim it would even last beyond 15 years. What are your
Aortic
thoughts on
prosthetic
that,
valve.
sir?
That is aortic prosthetic valve. No?
Yes, aortic prosthetic valve.
Yes.
I think overall aortic doesn't need so much of anticoagulation. mitral certainly needs a proper INR and probably INR around 2.5 or above. That is the correct value. Any of these patients were also in atrial fibrillation, Dr. Krishna?
No, sir, they were not on atrial fibrillation. In the first case, what we have done is he is in suboptimal range. So we thrombolized with the tenecteplase. Even after tenecteplase, he doesn't improve the gradients, and the thrombus was still there. So we again thrombolized with first we thrombolized with altiplase, then we thrombolized after 3 days with tenecteplase, sir. After tenecteplase, we had good results, and the valve was opening, and there was no thrombus visualization. And he improved clinically also betterly. After that, we targeted INR around 4 because he had a struck valve. So we decided to target him on higher range, like 3.5 to 4.
All these valve survivals following clot must be assessed with a TE pre-discharge. And we must make a correct judgment whether the patient is going to need a re-replacement soon or okay to go for many years. I think that decision is also very, very important. It's not always that the patient forgets to take anticoagulation. It is also could be a problem with valve.
And
All right, Dr. Omkar, can we move to the next case?
Omkar and Emcure would be happy that their tenecteplase, Elaxim, is also used in prosthetic valve thrombosis, off-label indication, but it saves lives there. We have seen patients. It works.
Even intracoronary also people.
Intracoronary, we are collecting data, we said, in acute MI. Anyway, okay, go ahead for the next case.
So we have Dr. R. Pradeep Kumar to take this case forward. So, sir, over to you for sharing your slide deck and taking the case forward.
Okay. Thank you. Good evening, everybody. Just give me a moment. I'll just share my chart.
Dr. Girish, this Bangalore traffic, I think you will not reach home before we finish.
I am glad to learn while I'm traveling, sir.
Technology makes it possible.
Wonderful, unbelievable. But you know, the one that you told me, I think if the valve is stuck, the great thing is catheter may definitely help, Dr. Srinivas, as you said. If there's a cardiogenic shock and you see the valve leaflets not moving, I think more than thrombolysis, getting the valve to start moving is a great benefit. I think that could have been a couple of instances where you said catheter really made the difference.
Yes, sir.
How do you do it? I mean, aortic valve is easy to understand. Like you just put a catheter from groin or radial and shake the valve.
Retrograde, he went to retrograde and put a catheter and pushed it up, sir. Guide catheter pushed in LV, then again pushed another catheter up, retrograde. Like how you initially did retrograde aortic, the same thing. Otherwise, in Triple M, they did transeptal. That was a planned elective procedure.
Yeah, I think going across the septum is probably easier and more definitive.
Yes, yes.
All right, let's hear from Dr. Pradeep Kumar.
Yeah, good evening, sir. Today I'm going to present endovascular stenting of coarctation of aorta, that is coarctoplasty of a young adult. This was done almost a year back when patient came for follow-up also. So just I'll briefly present first 4 slides regarding a brief introduction and revision of regarding the coarctation of aorta. By definition, coarctation of aorta is localized narrowing of aortic lumen by a ridge and composed of medial wall thickening and infolding of aortic wall tissue. Narrowing is commonly it's adjacent to the opposite to the insertion of a PDA, that is juxtarectal, but may also be proximal or distal to the PDA insertion. And it accounts for about 5 to 8% of all congenital heart diseases, about 4 out of 1,000 live births with male predominance. It can occur as a solitary lesion, but often associated with other cardiovascular lesions such as bicuspid aortic valve, which is common in about 50 to 75% of the patients. Other associated lesions are aortic arch hypoplasia, subaortic stenosis, mitral valve abnormalities, VSD, ASD, PDA. And the most important non-cardiac associated lesion is cerebral aneurysm in 2.5 to 10% of patients with coarctation of aorta. And the acquired, this is another non-cardiac anomaly. It's not, rather it's a acquired thing, acquired intercostal artery aneurysm. High degree association with gonadal dysgenesis, that is Turner syndrome. And out of patients with Turner syndrome, 35% have aortic coarctation. And the indications are supine non-invasive pressure gradient more than 20 millimeter of mercury between upper and lower limbs, peak-to-peak gradient of more than 20, or peak-to-peak coarct gradient less than 20 with radiological evidence of significant coarctation with significant collateral flow. Or if there is a pathological blood pressure response during exercise, or if there is significant left ventricular hypertrophy, or hypertension with more than 50% aortic narrowing relative to the aortic diameter at the level of diaphragm. And if left untreated, mean survival of these patients with coarctation reduced to mid-adulthood due to long-term sequelae such as congestive heart failure or infective endocarditis or aortic rupture or cerebrovascular hemorrhage. And life expectancy depends on severity of stenosis and associated anomalies. Now, coming to this patient, this guy is a 33-year-old male who presented to our emergency department with accelerated hypertension, and blood pressure was 220 by 100 in the right upper limb. Initially, the emergency guy was seeing, and then they called us. So clinically, the femoral and dorsalis pedis pulse was very feeble, and BP was hardly 80 systolic in both the lower limbs. And he was a known patient of systemic hypertension, diagnosed about at the age of 20 years of age. And he was on telmisartan 80 milligram, hydrochlorothiazide 12.5, and amlodipine 5 mg. And he has such episodes of accelerated hypertension once or twice in a year, and he gets some treatment in the emergency department. Once the BP is reduced, he was going home. So this was going on for past almost 10 years. And he did not have any history of lower limb claudication. Then we started evaluation because there was a blood pressure difference between the upper and lower limb. We started evaluating. ECG showed sinus rhythm with LVH. Chest X-ray showed rib notching. I'll show you the chest X-ray images. Rib notching at the undersurface of right third to fifth ribs, more prominent on the right side here. And echo showed concentric left ventricular hypertrophy, tri-leaflet aortic valve with ejection fraction 60 to 65%. And then we got the CT angiogram done, which showed classical narrowing of aorta about 22 millimeter distal to origin of left subclavian artery. So this is the chest X-ray showing rib notching on the undersurface in third to fifth ribs here. Then this is a CT aortogram. This is a recon images, which is showing around 20 to 22 millimeter distal to the subclavian origin. There is a narrowing followed by a aneurysmal dilatation of aorta. This is a axial section showing the narrowest segment, which is around about 12 millimeter in diameter. Here it's a widest diameter, I mean aneurysmal part, which is 26 millimeter in of the descending thoracic aorta. And this is a coronal section showing the same CT angiogram. So then we counsel the patient, and we have taken the patient to cath lab for coarctoplasty. So initially I started the lines, then only this procedure was done under general anesthesia. But before taking the patient under GA, first we started the line because I thought it is easier to take femoral line before GA. Once BP falls, it will be further more difficult. Though I struggled a lot, but finally with the ultrasound guidance, I got access with the right femoral artery. And I also took a left radial artery access for angio from above. So right femoral artery, initially 7 French sheath, 11 centimeters from Cordis sheath, then proglides were prelayed. Only I've taken only one proglide at 12 o'clock position. Then upgraded the sheath to 10 French. And in the left radial artery took a 7 centimeter 6 French sheath. This is a usual Terumo sheath. Then patient was taken under GA. And after that, this 11 French sheath, small sheath was exchanged with a 10 French femoral sheath exchanged with a 14 French 75 centimeter long Cook sheath. And initial hemodynamic data was arch pressure was 183 say by 96, and right femoral artery pressure was 94 by 56. And after this, patient was taken under GA. So this is the pigtail angiogram. The pigtail, the marker pigtail was taken from the left radial artery and positioned in the ascending and arch of aorta. So here in subsequent slides, we'll be seeing the videos on the on right side of the screen, and left side will be showing the still images. So this was the image, I mean, see angiogram from the left radial artery axis. This is from the crossing this lesion from the low was easier. I crossed it with the 035 Terumo glide wire. Then on that I took initially JR, then took a stiffer wire and exchange with the pigtail catheter for an angio. This is angio was done. Then after this angio, sorry. Here, this angio was taken to just to see the what is the diameter at the level of diaphragm. So these are roughly around 20 to 21 millimeters. Then because wire crossing was easier, I again crossed with the same Terumo glide wire. Then took a JR 6F JR. Then exchanged the wire with the Amplaz super stiff wire, and then took this long sheath, Cook long sheath above the Amplaz wire and positioned it in the arch of aorta. Then I took a Andromed XXL. It's around 57 centimeter long covered stent, and I crimped it over 20 into 60 millimeter boa balloon. So this is the sizing chart. Here the lower one is the 57 XXL. This sizing chart, this starting was from, I mean, here above there is no labeling, but it's a starting one. Starting first column is 12 mm, 12 mm balloon. Then 15, 18. This fourth one comes to 20 mm balloon. So if we are dilating this 157 long stent, XXL stent to up fully, then it will come to around 51 mm. So this was accepted from the measurements what I have taken and prior to the, I mean, in the CT angiogram. So then I took this crimped stent inside the long Cook sheath and positioned it across the coax segment. I positioned it just distal to the origin of subclavian, just so that not to disturb any subclavian flow. This is the stent deployment scene. Initially, I thought we'll go very quick, but it took a long time because the volume of was so. I mean, it's almost like a 40 ml of volume it required. But
to
still,
rapid pace the heart at this time.
This was on the low side, sir. It's around 60 to 70, I think.
But is there any need to rapid pace the heart?
No, so that we do when we are doing a valve or ascending aorta, but usually we need a rapid pacing. So in the, I mean, with the fear of whether it will pop out or it will go down or what. But during coactation stenting, we never need any rapid pacing because there is a outflow and the like innominate or corner carotids are there. So we need not go for a rapid pacing. But here, despite going to
length
full
is
volume,
also quite long.
Sorry, sir. Yes, sir.
Yes, so you are unlikely to miss the cord segment.
Yes, sir. So still, after pushing the entire volume of the inflation device, still I could not fully inflate. So what I did, I added extra another 5 ml of normal saline to the balloon, I mean inflation device. Then again re-inflated. I'll show you. This was the angiogram after first inflation. So still I was not satisfied with this one. So again I took extra volume and re-inflated this one, but took a long time. As you said, it took a long time because it was a very high volume inflation device, that barred one. Usually it comes with a 40 ml capacity. Still after the second, initially I took only 30 ml, but after that I added another 5 ml. So this was the one after the initial inflation. I mean, after second inflation. Here I accepted this much of waste because I thought below is an aneurysmal segment, otherwise it may drop down. So I intentionally left a waste there. And then I removed the wire. And this is the final angiogram from above. And here the still image. And hemodynamic parameters are arch of aorta at the end of the procedure was 126/76, and femoral artery pressure was 118/74. And this patient again came for a follow-up, so just to see is there any edge dissections or what, but nothing was there. And even blood pressure medication again, just now he's on only telmisartan 40 mg 1 tablet only. With that, his BP is maintaining around 130 systolic. So these are the long-term complication which can happen locally at the site of coarctation. After coarctoplasty, there may be recoarctation or aneurysm, dissection, or rupture, or fistula, or endocarditis. In the ascending aorta, same aneurysm formation because of the medial weakness, or dissection, or rupture, or sinus of valsalva fistula. Because there is an association of bicuspid aortic valve, this may lead to stenosis or regurgitation. And LV, because of the left ventricular hypertrophy, there may be systolic dysfunction or diastolic dysfunction, or may land up in heart failure or sudden cardiac death. Coronaries may lead to premature atherosclerosis and ultimately ischemic heart disease. And because of the aneurysm in the cerebral and brain, there may be aneurysmal bleed, intracranial bleeds, or stroke. And other systemic complications are hypertension and reduced exercise capacity. Thank you, sir. Now it's open for discussion.
So when we talk of indications for treating the coact, what is important? The pressure difference between ascending aorta and descending aorta? That means the gradient across the coact.
Yes, sir.
Is that the one which is going to guide you, or you anyway treat coarctations?
If a gradient is more than 20 millimeter of mercury, or if it is less than 20 millimeter of mercury pressure with significant collaterals, in that case, we may not get a gradient.
Yes, I think collaterals reduce the difference of pressure between ascending aorta and descending aorta.
So that's why there is one more indication, sir. If there is if the diameter of the coact segment is less than 50% compared to the diameter of aorta at the level of diaphragm, that is also one of the indication.
50% of the level of the
aorta
diameter
at
of
the
the
level of
aorta at
diaphragm.
the diaphragm.
Yes, sir.
Yeah. Srinivas, you want to add anything?
Pradeep, are you, all of us might do occasional procedure, but just for information, are you pediatric cardiologist or adult cardiologist, coronary? And
No,
this
sir, I'm adult
question?
cardiologist.
Okay, good. Then you should be congratulated for doing this. But what a few words of learning points, what I thought is, first, all of us, this is a very pathetic of 10 years that secondary, not in your center, some other center, the secondary hypertension was missed. There, the boy was giving you as enough opportunities to say that I am secondary hypertension, because intermittent rise of pressure, sudden worsenings, again improving, then all that would suggest that probably you should search for secondary hypertension. And
Oh.
clinical evaluation, clinical examination, though it is becoming out of fashion, but here it is becoming very important. You just check blood pressure especially when it's severe hypertension, you should check blood pressure in lower limbs. They would have made out the difference. And obviously, if you didn't palpate the pulses, that is a different story. At least blood pressure checking, that is, there are 2 upper limbs and 1 lower limb is mandatory, especially when the patient has a severe hypertension.
And that too at
such
a young age, no?
young age, 22, first he presented. That means you have to rule out a coarctation. That is the learning point for evaluation of hypertension, which is very basic. And then he's almost telling you that he has coarctation because blood pressure in lower limbs is hardly less and less femorals and all that. But
sir.
finally, you did a good job by diagnosing, and that picture which you showed, rib notching, is quite good actually. Chest X-ray, somebody has taken chest X-ray also, they would have made out that rib notching. And the finger, the 3 sign, what they say, or if you do an iotogram, the reverse 3 sign, all that could be demonstrated because of aortic arch injection which you have taken. So
Yes, sir.
few words of caution I would say while doing those. Indications you have already showed enough, but obviously the main indication here is blood pressure, uncontrolled blood pressure. So
Yes, sir.
gradient is come well, but sometimes gradients, even if it's not coming, then still if it's uncontrolled pressure, we would try to treat that. And one thing, one word of caution, though interventional cardiology would like to do coarctation, artery like this with a stent, we also have done, but it is not a primary indication. First recommendation is to do a surgical repair with if you required a flap, because that's the treatment of choice in such patients. Because restenosis rates could be high. But where is the coact stenting? The recommendation class 1 is if a surgeon has done a job and recoacts, then that becomes a class 1 indication for stenting. But just for learning sake, I'm mentioning. Then coact stenting, once we are doing the procedure, I think pediatric cardiologists should knowing that why that pacing you are asking. No, sir. Pacing is generally not recommended, not indicated here because the blood flow is, all the pulsatileness is taken to other arch vessels. By the time it comes to low, it is less likely. Other thing which pediatric cardiologists follow is bib balloons, balloon in balloons. So first what it does is it inflates inside balloon, stabilizes the balloon so that it doesn't move out or pop out, and then the outside balloon gets inflated. That bib balloon is a very good concept which avoids movements of the procedure while doing the procedure, because sometimes it could damage the arch vessels if it is not taken care. That bib balloon is a good concept. I don't know what balloon you have used. That bib balloon.
It's a single woman, sir.
But bib balloon advantage is if you don't have a covered stent, luckily you have a covered stent, sometimes you could also avoid the problems of rupture and things like that. But if you have a covered stent, though it is very expensive, it is always preferable to avoid sudden problems. But we have done some non-covered stents also when they were not available and the patient was desperate. Because covered stent, the cost becomes 1.5 lakh, whereas the routine stent, it will be 45,000. So without coverts, but always preferable to have a covered stent to avoid leaks. But one thing I would caution say that you are very fortunate. You never aim for a perfection. Okay, don't keep on dilating again. That cosmetic appearance of something is okay, but in that process, if you produce aortic dissection or aortic ruptures, then that will be not unforgiving. So don't aim for perfection there with a further dilatation and all that. Gradient would go away even with a little increase. Some restriction, some narrowing could stay. Actually, that helps in keeping the stent in place, as you said. If you totally make it free, then it could be moving in between. But never attempt for a perfection, because people have noticed.
My aim was to leave a waste there.
People have noticed ruptures, dissections in that. Fortunately, nothing happened in this patient, but always don't aim for total perfection like that. But otherwise, you did a fantastic job. Only thing what I thought is different was,
always put a covered stent, or
if available, possible, always prefer covered stent. Sometimes it is not available, sir. The ATM company makes it, and another company makes it. It's not available many of the times. As a desperate measure, we did use routine stents also, which is used in aortoarthritis, things like that. We use same stents we have used there also. But you should also be cautious. You mentioned how the stents shorten. That's also important. But one thing I would say, what I would have done slightly different is little longer. The stent length was little longer, I thought, because it is projecting into the dilated aorta. So if you have, sometimes it's easy to say, not available, lens are not freely available what we want, like in coronary. But if possible, you can take a little 10 mm less stent so that the projection too much into the dilated portion of aorta could be avoided. So that will again little different. And but finally, you did a great job, and the patient improved, and nothing happened. God is great. But what I would say is, you can take a little shorter stent and don't go too much higher diameters
True, sir.
to see for perfection. So a little of residual waste is always good. And then that did a good job. That means the pressures have decreased. Blood pressure is decreased in that patient. Still, they might require little doses of antihypertensive therapies and follow-up. That's
Yeah.
what we have seen.
True, sir.
And other important thing which we have noticed is you have used a 12 French and Perclose. That much may not be needed. This sheets, which are outer diameter is 8 French only, but inner diameter is like a 9 French. How we call it slender sheets for radial. Same thing are there for the femoral sheets. There you need not use Perclose or anything. But it goes in 8 French. Each stent may have a different diameter. Your recommendation was 9 French, I think.
9
That's
French,
how
but
that's how you close with the Perclose. But sometimes we may avoid that also. But if possible, you can always close it, and patients are more comfortable. Only thing is cost keeps on adding.
no, sir.
in
That
such
9 French was like a diameter of outer diameter of the crimped balloon.
Mhm.
But that needed
Stent is further bigger, is it?
required sheath is plus 2 French. So 9 plus 2
Okay.
is 11 French.
Maybe, but sometimes this Mullen's type of sheath with dilators, no, which we take directly there, the inner lumens are bigger, unlike the coronary guides and other guides. That's
Okay.
what I was just trying to say. I
Okay.
think overall you showed a very good case, and patient did well on follow-up, I think. Other thing why surgeons are worried to touch such patients is, especially when the collaterals are coming, they're worried about producing paraplegias also. While surgeon repairing, then they are also worried about producing, because of collaterals occlusion, patient could develop some paraplegia-like complication. That's why surgeons are also, they always ask us whether you want to do it. Then, but sometimes such procedures, if you can avoid it, there's nothing like it. Surgery is totally avoided in this patient. And you put antiplatelet drugs. What is your protocol? What did you do?
Yeah, I just give only initially for 3 months dual antiplatelet. Then patient is now only on ecosprin.
Yeah, I think after 6 months, we change over to only ecosprin, and maybe little statin also could be helpful, because to prevent this. Restenosis rates, though the described, are less common. Significant restenosis less common because lumen which are produced is much bigger.
Yes,
For the
sir.
sake of information for all the doctors who are listening, latest December 2022, ACCHA and has come out with a good guidelines for aortic disease, which were long awaited. And it has covered aortic aneurysms, how the size, dimensions, progression, then Marfan syndrome, what is the difference in the changing the treatment patterns, and how it has to be addressed in pregnancy, and post-coact subclavian dilated aortas, how to be dealt. All that is covered very well in that guidelines of December 2022, JAC or circulation. I request all of you to go through it. But some silent points which they mentioned was, the previously we always used to think that we can wait till it crosses 5.5. But if technical expertise is there, now they say at repair, the dilatation, even if it is 5 centimeters, you can send for surgical repair. And then if it is Marfan syndrome, they've decreased it by 0.5 further, 4.5 centimeters itself, you can send them for repair. And then other things, what they've also covered very well is in these patients who have like a repeat procedure, like a TAVR, or how they are followed up, all that is also given very well described. It's it takes more time to further talk on it, but all of you can refer that. It is a quite good guidelines. And last time it came, I think, in 2016. Now I think it reviewed in 22. And aortic dissections, type A, type B, all that is very well described. A lot of confusion used to happen. Recently, we had one patient who had aneurysm, 5 centimeters, asymptomatic. What to do with all those things are clarified. How the aneurysm is increasing per year, 0.5 centimeters, we used to think per increase per year is again an indication. Now they said the slight modification there is, if you parallelly follow up, then even if it's 0.4 increase, still it is an indication. Because we have more expertise, and even the percutaneous procedures like TAVR, they said are a good alternative for surgical management of those procedures. So those are some of the things which are relevant for your presentation, I thought. Thank you. I think we have...
What age you think we should address cough? Like say, a baby is born and you diagnose cough at say age 3 months or 6 months. I mean, the need to do balloon dilatation at a young age, like less than 1 year, and then do another procedure when the child is fully grown. Is that the way we do it, or you like to wait?
As Srinivas sir said, the first choice is always a surgical correction, sir, especially in pediatric population. But still, if it's not approachable, then the best, the next alternative is a ballooning only. And but thing is that with ballooning, there will be again recoactation.
No, you should be ready for a repeat procedure like yours at some age. Maybe when the child is fully grown, age 18 or 20.
Yeah.
Only when there is failure to thrive, sir. In the heart failure, sometimes severe cox could present with heart failure. We have seen a 2-year-old girl had that child. Then we did brain dilatation, but by and large, they say in early thing, then probably surgical patch iotoplasty, what they call, could offer better results than compared to stents, because the child could overgrow with the stent. Again, you would need a second procedure. So unless there's a definite emergency indication or a heart failure or child is not suitable for surgery, by and large, I think iotoplasty procedure in surgically is recommended. But sometimes emergency, we have done aortic balloon dilatation in one such patient, I remember. Sometimes they could also have this renal artery stenosis. Did you notice anything like that? Aortic aortoarteritis, we see more like that. But berry aneurysms and all are described, but we didn't see much, luckily.
This patient, CT angio didn't show any renal arteries, but even I didn't get any renal artery any article anywhere.
More aortoarteritis type of scenarios.
Exactly. Takayasu arteritis, those things, those are all the branches of aorta, arch of aorta or abdominal aorta. Those are usually at the ostium, they are stenosed. Yeah,
our experience is more in such cases actually, because we deal with more of adults. But pediatric cardiologists, I used to work closely with Nageshwara before in earlier hospital. We did have some, because we used to help him in cath lab procedures only. Rest all he used to take care. I think that way it is good. Girish, any comments?
Length, sir, I intentionally took because I wanted.
Sometimes the popping up worry will be there.
2.5 centimeter above and 2.5 centimeter below. So I thought around 5 centimeter length, final length I need. So that's why I selected.
But it is projecting into the, projecting into the dilated thing, no? But anyway, nothing will happen. God is great. Girish?
No, just one comment. There is this stent that which you can go on progressively dilating as child grows, as the aortic size increases.
Yeah, there's another stent which is there.
Absolutely. So since it's an elective procedure, I think it's better to plan all your hardware and choose the right hardwares and the implants, and then carry out these.
Do you remember, Pradeep, the name of the stent which Girish? I also forgot the name. You can, it also expands with time. You can put a bigger balloon and dilate it. That's what they say.
Keep dilating. Very true. Thank you.
Those things will be with probably with a self-expanding balloon expandable. I don't think.
I don't remember, but it's a balloon expandable stent only.
It is a balloon expandable stent.
With increasing age, with the diameters increasing, you can dilate further, they say. But it's always preferable to have a covered stent available even when you're doing that.
Yes, very true. Same Andromed have even uncovered stents also, but I had a fear if it ruptures, I don't will be having any backup. So I thought better to take a cover stent.
Good case. I think Krishna, you want to say anything?
No, sir. Everything was discussed, I think so.
No, but it is totally different discussion. Hiramat sir and we were actually surprised. I just saw before logging in. Initially, what they have sent had only names of people who are present. He didn't have the cases. I thought routine coronaries will be presented. But suddenly, when I was trying to see the faculty link, I saw about 15 minutes back that it was totally different cases. So no thrombosis. You did some justice to title Krishna by showing the thrombosis in prosthetic valve. Coarctation is anyway totally different. But I think we saw good cases. I think audience also should not have any repentance for joining. No, good case.
Sir, I missed initial Krishna's case. Probably he thrombolized
yes, thrombolized.
So even in my experience, I have thrombolized with streptokinase for 48, 72 hours. I keep daily checking with the echo and fluoroscopy whether valve movement is there or not, and for the gradients. But most even I mean out of 10, I think 7 they opened up well with the streptokinase for 3 days continuous infusion and without any bleeding.
Yeah, that's what I was also mentioning. And the opening rates may be further better with tenecteplase, which was more clot specific, fibrin specific. And we did see good results even in patients with PANAS. That's what I was mentioning. Giving this was helpful. Because acutely, immediately, a lot of stabilization happens. Even human body is great, even if gradients decrease by 10, and even if little flow comes forward, then it improves. So that's why even little PANAS, over which there will be definite some clot also. So we have seen patients improving, and we did give lysis in spite of INRs being high also, because sometimes there are a lot of mechanisms in the body which are difficult. Though in spite of INR being high, still he clotted. So something like that we did try in 1 or 2 patients, and nothing happened. And but only thing is 1 or 2 patients we noticed embolisms. That is, you should be careful.
Yeah, true, sir.
He stuck well when you hit with a catheter. I mean, I never had a chance to do that, but you just hit the valve with the pigtail
Yes,
tip.
yes, yes. Poking only.
Okay.
And yeah, that is an emergency done. Whereas they crossed it with a wire and then put a balloon.
Okay.
But I think we need a filter or something if we are ballooning.
Yeah, later on when they did electively, they put filters in carotids. And first emergency case was done without filter, then his patient developed stroke. But later on they advocated that I think 4 patients or something was presented from Triple M, where they use filters.
Filters for what? I mean,
Carotid protection, sir, stroke prevention.
You're talking of co-op? No?
No,
sir.
he's asking
Previous,
prosthetic valve thrombosis
prosthetic
when you're
valve.
dilating.
Oh. Okay, Dr. Omkar, are there any other presentations?
No, sir, there are no presentation further, sir. These are the 2 presentations that we.
Srinivas, you want to present something?
I was not told, sir. Just few. I thought there otherwise I've done. Even if now I can do it, but it's 9 o'clock, 9:05 already.
Take it from here.
Yeah, but one thing which is very important for everybody, which is very basic, which I want to highlight is not to miss coarctation, not to miss secondary hypertension, because patients have blood pressure by 220 by 130 in a young fellow, 23 years, you have to suspect secondary hypertension. No, you can't miss it. And people are giving, and how many amount of antihypertensive you give, how will it come down unless that is relieved?
Exactly.
That is another evidence to say that please search for secondary hypertension. Patient is coming to you again and again, 1 year after the year, and then finally after a decade, it came to the wisdom of Pradeep to diagnose it. Otherwise, any doctor with such a high blood pressure, especially in young, first thing you suspect is secondary hypertension. I think coarctation comes on the top in the priority. I think that the point also is very highlighted.
The echo people also should be able to pick up.
Yes.
Like,
and if you put a stethoscope also, sir, murmur comes, sir, in the interscapular region.
Definitely, there will be a scolet and flow murmur.
It's a dead instrument. No?
To make it interesting, sir, the stethoscope. I often practice this nowadays. This instrument of iPhone is great. Now the Echo or even the Litman did it. You record the stethoscope and that app is there, and it gets recorded in your phone. And you can amplify it and listen on the phone, and it can be transmitted anywhere. That's a very good value addition in auscultation. I recommend all of you to practice that, and it's very good teaching tool.
Sir,
And all the types of murmurs. Initially, we didn't have ECG coming there. Now, further modification came that ECG also is inbuilt in that same stethoscope, which you put it. You get ECGs and you get murmurs. So there's no worry of systolic, diastolic. Still, you get some disturbances, but still, it is a very good value addition, I think, for the auscultation. And generally, if it is a continuous murmur, I keep recording it for see the CRF patients who come for dialysis. So how continuous murmur comes very clearly. If time was there, I would have shown it. But it is all of you should practice that, I feel. And then further is the 5th dimension in clinical examination is introduced by Eugene Braunwald. I think youngsters, PGs, if somebody were there, I always keep asking. Recent DNB exam also, I was asking, Many of them didn't answer. Eugene Braunwald, Jagat Narula presented this, and it needed Braunwald's expertise to make us. It is bedside focused ultrasound examination is also part of clinical examination. So handheld devices now there's compatible, which are there, and nowadays they recommend bedside handheld devices also to be part of, and it is called as insonation. Inspection, palpation, percussion, auscultation. The fifth dimension of clinical examination is insonation. Insonation is a new term which is introduced by Braunwald, and it should be practiced, especially for such patients or pericardial effusion, LV function. There's a valve lesion. They're so easy, you know. If you're not auscultating well, at least if you put that. And the GE has made this bedside echo machine, VQ scan. That is about 3.5 lakh rupees. And the costly stethoscopes also nowadays are costing 1 lakh. And if further companies come in US, they're actually selling it on lease model. Butterfly.com, you can type it and go onto it, and you can get that instrument on lease. And then they're giving it to doctors. They're not started in India. I just asked them. But those things will improve our auscultation skills further. I keep taking classes for FIFA classes for undergrad students. I started demonstrating with that, and they've really liked it. And it is really useful tool for clinical day-to-day practice.
Improve auscultation skills, or auscultation will go?
No, sir. If you can't hear it, no. What you can advantage in this is you can increase the phone sound. The sounds come more. No. If suppose by age we are becoming a little more of presbycusis or something, you can increase the amplitude of the phone. It gets magnified.
Amplified.
Amplifies.
Yeah, amplified.
Amplifies. The only thing is that you get some
Very
disturbances in between. When they shake, when there is little of motion, you get some artifacts. But if you keep it well, and especially we remove the cloth and then put it on directly on the skin, you can do reasonably good thing. And then transmission on the internet. Now you can sit in Pune and auscultate here. And in times of COVID, that's a great value addition again to have telemedicine thing. And you have small only bell type of things which were there started. Now the same stethoscope, Littman did it, and EKO is a company, ECO. You can type in the apps, you get that app, and you can purchase the stethoscope. It's not very expensive also, some 35,000 or something, and they send it to home. If you want, you can use it.
So
Because I
even
thought this murmurs missing is too much, coarctation. That's why I feel it is very bad as a clinician, though we are interventions focused, but you can't miss out secondary hypertension.
And 10 years he's taking
10
antihypertensive.
years he is taking suffering, bichara.
Starting from age 20. So I'm
Yeah.
sure clinical cardiology also needs a revamp.
And this guy on emergency told me, sir, give me a Lasix dose, BP will come down.
He's also become a doctor for himself. Very nice patient. Huh? But these handheld devices are also useful value addition, I think. Many of us should practice that.
Really nice. I want
Sir-
my 667.
Right. Thank you.
Sir, IIT Mumbai has also developed this device, sir. So, and then you have a headphone. You have to keep the headphone and a small tiny diaphragm.
Yeah, it is conquered now. The technology is conquered. Then many of
So
them would improvise further and make it cheaper.
cheaper. Even you can amplify, as you said, sir, amplify, decrease, and even background noise and everything we can modify based on that.
I'll just show one recording. If I don't know if time is not there, but I'll try whether you can see it once. I don't know whether you can. This is it's coming. It's not coming. It's blurred, I think. A lot of shining. This is the Echo is app. Now patients. These are stored patients. Number 1, 2. It's all blurred. It's not able to focus. But I think if you see, I have when you are doing BMV, I record this before, I record this after, so that whatever MDM is there disappears. That way, a lot of learning happens. So you know that is a. I'll just show you.
Hello.
There is this new electronic.
Can you hear this murmur?
Meeting urgent.
No, Dakshina.
That the display is also coming as it's coming as blur on the screen. But anyway, that sort of things are possible. It comes as a phonocardiogram. Why it's getting blurred, I don't know. See those?
Yeah,
In
I
between
mean,
it comes.
you can just put it in front of your face, sir. It will come, I think.
Yeah.
Yeah, it's visible.
So that is a murmur. That comes. Again, you can press how many other times you want to listen. You can keep repeating. I'll show you a continuous murmur. That will come very well.
So you can make out it's a pan-systolic or continuous mid-systolic.
Everything. I have one renal transplant fistula patient. It's just too easy to demonstrate.
Yeah.
That's a continuous.
Yes, sir.
This all is coming in iPhone. So just for interest, because I had some time and relevant to clinical examination, I wanted to show it. Thank you. Shall we close, sir?
Yeah, I think so. Omkar,
Yeah, so
you can.
so thank you very much, sir. It was indeed a pleasure to have two interesting cases and the discussion led by our course director, Dr. M.S. Hiremat, sir, and our moderator, Dr. A. Srinivas Kumar, sir, and Dr. Girish Navsundi, sir. I thank our speaker, Dr. Krishna and Dr. R. Pradeep Kumar, for presenting two interesting cases. So with this, we'll stop at this point of time, but we'll gather soon and next month with 2 or 3 interesting cases. Till then, thank you very much. Have a nice time. Also, I take an opportunity to wish you a happy new year, because we will be meeting in the next calendar year only. So thank you very much. Happy New Year to everyone. And let's have a happy holidays also, and look forward to meet you in a next month. So Srinivas Kumar, sir, as you suggested, we can look forward for some specific case sets as you suggested. And
Hiremat, sir, I was telling that if they want different type of things, some complex high-risk intervention, PCI chip type of cases or something like that also can be shown if the audience is interested. That's what I was telling, sir.
No, we are in fact inviting them to come and present.
Yes, sir. That's what. So whatever types interesting cases they have, it need not be related only to thrombosis, I'm saying. Before also we were showing a lot of new type of cases.
Yes.
Structural heart and anything people want to present, it is always welcome.
No, Emcure has been very cooperative. They, I mean, though it is written as no thrombosis, the spelling is KNOW.
no.
So,
True.
so you know more about thrombus
Yes.
everywhere. You know.
Yes, yes. Okay.
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 Thank you.
you.
Thank
End
you.
of the year.
Thank
Bye.
you.
And let's get into new year in a happy mood and on a happy note.
Happy New Year.
Thank
Happy-
you.
Thank you.
Thank you, sir.
Bye-bye.
Happy
Thank you
New
so
Year.
much, sir. Thank you so
Thank
much.
you. Bye.
Have a good night.
Good night.